be heart blocks.
Right.
We are decoding Dr. Asif Ullah's notes to master the classification, the acute triage, and, well, the long-term management of AV node conduction failures.
And to fix that grid, you really have to accurately diagnose the exact malfunction.
Think of the AV node as that central traffic signal between the atria and the ventricles.
Yeah.
We want to see what happens when that light gets delayed or completely broken.
Exactly. So Dr. Ullah's notes map out 4 primary stages of severity here. First degree AV block is, well, it's basically just a slow green light. Every vehicle crosses, but conduction is delayed.
Right. So on an ECG, the PR interval stretches over 200 milliseconds, but it remains benign.
Yes, exactly. But then you have to ask, what happens when that traffic light's computer processor starts overheating, That brings us to second degree block, specifically Mobitz Surst, or Vinca block.
Where the yellow light stays on a fraction of a second longer every cycle.
Right. The gatekeeper just gets tired. The PR interval widens with every single beat until it completely glitches and a beat drops entirely.
Wait, let's unpack this for a second, because looking at the ECG, the sin is so much more dangerous. Both leave you with missing beats.
They do, but the difference lies in the physiological mechanism of the failure. Like I said, Mobitz is just AV node fatigue. The node basically just needs an extra second to recover.
Okay, so just...
The second isn't a glitch in the processor. It is a physical wire snapping underground, down in the His-Purkinje system, below the node.
Oh, what?
Yeah, the PR interval stays entirely constant, which gives you this false sense of security, and then it suddenly fails. Because the pathway, the risk of sudden death skyrockets.
So if the structural damage gets worse, the traffic light goes completely dead.
Exactly.
Which is third degree block, complete AV dissociation.
Right. The P and QRS are completely divorced. The atria and ventricles are firing entirely independently of each other.
And the ventricles just have to rely on a really dangerous, slow detour rhythm to keep pumping at, 20 to 40 beats a minute.
Yeah, at that point, the patient is likely crashing.
So moving logically to emergency treatment, how do you bypass a broken intersection in the ER?
Well, the standard algorithm points to atropine as the first-line drug for unstable bradycardia.
Wait, hold on. The notes specify that atropine actually has a notoriously poor response in these severe infranodal blocks.
That's right.
Like if they have Mobitz 2 or a complete block, atropine won't actually fix it.
No, it won't. And the reason is that atropine works by stimulating the AV node itself. If the structural break is below the node, chemical stimulation at the intersection is completely useless.
That makes total sense.
Yeah, so that is why transcutaneous pacing, or TCP, is immediately indicated for unstable Mobitz 2 or third degree blocks.
You just bypass the chemical receptors entirely.
Exactly. You deliver electricity directly through the chest wall to force the ventricles to contract. But while you are setting up that painful pacing, the protocol demands a rapid search for reversible causes.
Right, before doing anything permanent.
Yes. We use the mnemonic BL on CKS, beta blockers, Lyme disease, oxygen deficiency, calcium channel blockers, K for hyperkalemia, and STEMI.
And the mechanism behind these is so interesting. Take Lyme disease, for example. The bacteria physically infiltrates the heart tissue, right?
Yeah, causing direct inflammation right at the AV node.
It literally physically squeezes the conduction pathway.
Exactly. Or with hyperkalemia, elevated potassium alters the resting membrane potential of the cardiac cells.
Yeah.
It makes it mathematically impossible for the electrical action potential to fire normally.
Wow. But if you identify one of those reversible causes, like Lyme carditis, antibiotics reduce the swelling and the electrical signal usually returns.
Right, usually with no permanent hardware required at all.
But shifting to definitive management, what if the damage is permanent?
Well, non-reversible Mobitz to sick and third degree blocks carry a class I indication for a permanent pacemaker.
Meaning clinical consensus dictates it isn't just an option.
Right, it is absolutely mandatory to mechanically replace that broken signal.
Which leaves you with a fascinating paradox from the text's complications list.
Oh, the pacing-induced cardiomyopathy.
Exactly. We install permanent pacemakers to save the heart's electrical rhythm, right? To keep that traffic moving. But over time, the artificial electrical stimulation can cause the heart muscle itself to weaken.
Yeah, it's a very real late-stage complication.
It really leaves you wondering, how do cardiologists balance the immediate life-or-death necessity of flipping that traffic signal back on against the long-term risk of the very machine slowly degrading the muscle it was meant to save?